in terms of health for the people who started living there. And so today we're 41 urban health programs. There was an increase from 36 last year. There were some programs on the alcohol abuse NIAAA program that were added to Title V. Title V is one of the titles where the urban programs are mentioned in the Indian Healthcare Improvement Act. Next, please. So we have our membership across the nation. We are divided into 8 regions. Region 1, we have Baltimore, Boston, New York, and this is the one that is most to the east. So from the east to the west, we have 8 regions. One of them, for instance, regions 6 and 7, that'll be California and Southwest, are very large. And you may see that, for instance, we have covered most of the West Coast and the middle of the country. There's less programs for historical reasons on the east. And the ones that are marked in red are the ones that were added last year as part of the Title V of the Indian Healthcare Improvement Act. Next, please.
And just to also piggyback on that, also in red are the residential treatment centers. Some of them are actually dual programs in that they provide full ambulatory primary care as well as have residential treatment centers. So you'll see some programs on there have been around for some time.
Okay, great. So far in Title V, we have 21 full ambulatory programs. That means all weekdays they access primary care, 6 limited ambulatory with certain days and hours access to primary care, 6 outreach and referral. These programs do not offer on-site primary care. The urban Indian health service units and provide full primary care services, and the 7 NIAAA programs that are basically from the National Institute of Alcohol and Substance Abuse Services.
And from the listing of the folks that are on the call, it looks like we have a good number of you all coming from each of these areas. I think all of them. Thank you.
So the main goal of the family system reform program, especially this assessment, was twofold. To find out the current status of the UIHP sustainability system and to create a cross-disciplinary knowledge baseline that will allow the urban health sector, that means all of us, to be more strategic in regards to technical assistance. In the past, we have provided, as included also IHS has provided, technical assistance based on where they thought the need was, or if there was a program reaching out to them. But we wanted to find out what was the status of each one of the systems to know how we could customize a technical assistance and provide a more targeted assistance to all of you. And so in regards to this, we would like to follow up after these assessments with specific technical assistance in third-party billing systems, for instance. Then the next one, please. Oh, very early. Okay, so the assessment was conducted during 2017 and 18, and the components considered were basically health information technology systems that you all may be working on that, the billing coding system, and we decided to add the regulatory system since it is also impacting the previous two. The next one, please. So here we have is this the HIT? Yes. So I think I am going to leave it here with Dr. Fowler, who was in charge of that section. And so I will come back to speak to you about the regulatory assessment. Thank you. Dr. Fowler?
Yes,
yes.
Thank you. I also wanted to give opportunity for those that just called in that haven't announced themselves, just so we have a really good idea of who's on the call. If anyone just joined us and hasn't announced themselves, please feel free to do that. Okay. So moving into the Health Information Technology and Billing Survey, Alejandro mentioned the fact of why we had the goal of trying to capture some of this baseline information around HIT and regulations. But we did have two separate surveys in order to send them out to the appropriate people that could respond to them. So for the HIT survey, we wanted to capture your current status on billing, coding, and HIT systems, but also try to figure out what are the needs, and hearing that feedback from you all on what types of training you would need to inform in this current fiscal year in providing a community of learning or other types of training that could assist you to continue the work that you do. So we did this through an online survey. It was developed with feedback from Urban Indian Health Program sites as well as tribal sites that were both utilizing RPMS and non-RPMS systems. You may have taken part in that survey. Your executive director may have provided you that survey to fill out some of that information. So thank you for that assistance in providing that information. We did allow for PDF and electronic submissions in case there were some technical difficulties for submitting online, and also provided technical assistance to those that needed more detail in answering the question. And all of these surveys were analyzed by NCUI staff via some of the analysis that can be done in-house or online, I should say, through SurveyMonkey as well. So I'll be presenting that information here today. So the makeup of the Urban Indian Health Program respondents to that HIT survey primarily consisted of full ambulatory programs, although we did have a few, a makeup of all the types of UIHPs actually. So 4 outreach and referral, 4 limited, and 2 former NIAAAs were also respondents on this survey. So I think we had a good amount of feedback from all of the different types, which was very helpful. We did ask the question on whether your organizations had health IT on staff. This was important for us to understand if you were receiving your IT needs directly from your area office or if it was able to be provided in-house. The majority of respondents actually did have some staff, at least one FTE, dedicated to HIT, which was actually very informative that funding was present to have that HIT person on staff. And then as far as receiving technical assistance or training, in-house or outside, 30% felt that HIT staff had adequate resources for trainings and technical assistance, whereas 42% felt that they were only mostly adequate in receiving those trainings and technical assistance, and almost 27% felt that they did not have adequate resources. And some of the comments that came back from that was just stating that they didn't have enough staff on site to assist with the IT concerns of your clinic or program, and then also possibly needing additional assistance as they were possibly moving off of the electronic medical record system that they were currently using. So kind of keeping in the back of their minds that they would need future technical assistance even if it was adequate at this point. And when it comes to how that funding supports IT, majority of the urban programs said that they did not receive direct funding, that funding primarily or I should say that assistance primarily came through the area office. There were 54% that said that they received their funding directly through the area office for IT, whereas 27% actually said that they don't receive funds from IHS for IT. just something to keep in mind as far as like increasing the amount of funding that UIHPs are receiving for IT. We also asked questions around electronic health records in general, including RPMS, where we just wanted to understand if the programs that took the survey actually were using an electronic health record system. And 77% actually are using AHR, but there were a few that did not currently use at the time of the survey, did not currently use AHR, but had plans to actually implement. And about 4% actually had no plans to implement. So it would be helpful to hear some feedback on if any of those that were not planning to implement, what were the sources or the reasons behind not wanting to implement. We also asked specifically what type of electronic health record systems are being utilized. The majority at 76% are using RPMS or IHS electronic health record systems. And then otherwise were being listed as using eClinicalWorks, and then in that other category that says 28%, it's actually systems such as Therapy Notes, Athena, and Allscripts, and then Quantum. And there were actually a couple of programs that actually had developed their own SQL databases in order to help with capturing some of that information as well. So we can see that majority of our programs are utilizing RPMS. We also asked whether the current system for care to coordinate outside of your facilities was a possibility. And 60% actually said no, that there was not an availability or an ability to coordinate care with tribes or local health departments or clinics and hospitals. So we do see that as a need to put in place in the future, and recognizing that there's that need to have interoperability with other facilities and other systems is really important and needed. We also asked whether they were able to coordinate services with the VA, specifically, and Alejandro will get more into that topic, but specifically with the VA and understanding how reimbursement can be captured through having agreements with the VA. And 95% of programs do not currently have any type of way to coordinate with the VA, which is important to know. And I think as we move forward with some of the advocacy, making sure that that's being put in place is one of the priorities of NCUTI itself. We also wanted to find out a little bit more about HIT operations itself. So whether you are able or currently to provide telehealth services for your patients, whether it be medical, dental, behavioral health, or other areas. And 88% of you all actually stated that you do not currently provide telehealth. We know that telehealth is a large priority at IHS and in general for medical care to make sure that your patients have other ways of accessing care if there are any barriers to make it to your facility. So I do know that one program stated that they provided telebehavioral health using a commercial platform. So it may be an easier way of doing that through the non-RPMS system. So we wanted to dig a little deeper around RPMS and hearing some of the feedback on who was utilizing RPMS and if there were any challenges or successes around using RPMS. So we asked whether programs currently are using RPMS at their facilities. 70% said yes. However, there's a second larger number of people that actually said that they have not and actually are using other systems other than RPMS. So they actually were never on RPMS. They directly started using some other type of third-party system. We dug a little deeper just to hear specific feedback on RPMS, and we can see that some of the challenges that were reported were around not having enough support, or because of transitions in staff, it was difficult to onboard staff around RPMS. The data reliability was a high challenge, as well as the inability to have accurate and quality data coming out of RPMS. And you can see others that are listed here just around those challenges. So when we talked about those that had or are considering switching from RPMS to an off-the-shelf system, a commercial off-the-shelf system, we were trying to understand what might be some of the challenges to do so. And overwhelmingly, we saw that the response was the funding, the cost in doing so. So almost 91% stated that the cost was a large impact on trying to move off of RPMS. But we also saw other areas, such as it being a disruption in providing service or care during that transition or that switch, and then that there were some additional hardware needs that would be required, and then also just staffing being adequate to do so. So UICs additionally reported challenges in the area of support for RPMS data migration, that there would be a loss of revenue during that switch as well. And definitely if you have questions, feel free to let me know. I'll be happy to answer any of those. So in thinking about the future needs of not only the EHR system itself, but also for technical assistance, we heard responses saying that it is a need that the system have a user-friendly interface, making sure that there is an interoperability access on that system, so the ability to, when referring a patient, being able to have that information flow to you and from you for labs and things of that nature. Also that making it more efficient and able to support reporting requirements. So when we think about programs that are FQHC or programs that have other reporting requirements, not having that easy ability to capture that information is definitely needed. There was a suggestion for integrating with clearinghouses for billing in future system needs. Also, having a usable patient portal. We know that patients sometimes actually have an idea that they would like to be able to use a portal in order to find out some of their records or even setting up appointments. So having some type of system where you can do that is important, as well as supplying educational materials to your patients. Having a system that can do that. So having alerts or notifications about health aids. Also the ability to capture quality progress notes, that would be on the provider side. And then also capturing quality, being able to capture, to show that your work is efficient and is of quality for headquarters at IHS. So making sure that information is accurate with what I would lean more towards that being a part of and meeting those needs and requirements. The other area that we looked at beyond EHR was actually specifically on billing. So there were a few questions that were asked around that, and one of them was trying to just understand if our programs have access and ability to bill to different resources. And so you can see here that majority of programs are actually billing or able to bill to Medicaid or CHIP, as well as private insurance was a close second, and then Medicare. And then actually more than 56% said that they are utilizing self-pay as a way to capture reimbursements as well. What I can say is that for the full ambulatory programs, it seemed that insurance verification and accuracy of patient demographic information were some primary barriers that we saw around third-party billing. So those areas may be areas to provide technical assistance in the future. So understanding better how to verify insurance data. So for billing purposes only, we also asked what system was being utilized, because it may not have been RPMS, even though that was the majority that were utilized for systems. We did see that RPMS, 48% are utilizing RPMS to bill, but we also saw that there was a higher number in the other category where they were using systems such as Centricity, Provide One, Allscripts, Euromed, and even EasyClaim in order to do the billing. And you can see here there are some programs that are using the more well-known non-commercial systems such as NextGen and eClinicalWorks that are also stated here at a lower number that they were utilizing that for billing. When we thought about or wanted to talk about the types of billing by program type, we saw that 7 are utilizing RPMS for billing for full ambulatory programs, whereas for limited programs, Quantum was listed as one of the sources, but also RPMS. And you have to remember that for full programs, there were 18 respondents to that, so 7 of the 8. And then for outreach and referral programs, only 1 was utilizing RPMS, while the others weren't utilizing any type of EHR system. And for those NIAAAs, where there were 4 respondents, none of them are actually using any type of system for billing. So they probably are not billing at this point in time. And then lastly, when thinking about challenges around billing, it was stated that, or it was reported that insurance verification and completing that documentation in a timely manner were primary challenges for third-party billing. And then for smaller urban Indian health programs such as the limited or outreach and referral programs or former NIAAA, challenges were really referred more so to accuracy in coding, system functionality, and negotiating that reimbursement. So in other words, providing justification for being an F2HC was sometimes a challenge just to get the correct billing rate. And then so looking at that more so in a graphical form, we can see here that all of the types of challenges that were listed were actually selected for on a pretty high number percentage, that is. But we do see that there was a reporting that their American Indian and Alaska Native patients were unwilling to provide accurate demographic information. So being able to capture demographic information really put a buffer in the way of billing accurately. And then also the smaller UHPs thought that also negotiating reimbursement was that issue. So this is more just a graphical representation of what the previous slide stated. Lastly, we asked questions around technical assistance support. So whether there are TA or training topics that respondents desire to see offered in support of HIT needs. And we saw here that there weren't really any true standouts, if you will, for suggested trainings. Almost all of them were selected at almost 50% or more. But I will say that meaningful use standards, better information around GIPRA and fee schedules were maybe some of those higher topics that we saw that are around 6%. But there seems to be very little interest seen for PPS review training. So it sounds like that is something that's manageable for most of your sites. So that's helpful to know. I did put a few slides on here around accreditation, but I think for the timing of this community learning, I think I'm going to skip through those, and so we can get to the regulations and then also hearing some feedback from you all. So we just asked some questions around who was accredited and what were those challenges, and if they were looking forward to accreditation itself. So in summary, for the HIT and billing survey, we saw that some of the most pressing needs and challenges really dealt around the RPMS system itself, and that there were some limitations in the use and quality of information, as well as the service being provided to your patients was affected by that. Other main concerns were that differed by UIHP size. So challenges with HIT depending on the size of your facility, and the types of services that you're providing. And then also that overall, it seems that in order for the urban Indian health programs to advance around HIT, and especially in being able to be reimbursed for services, that there needs to be more support around infrastructure, and which basically comes down to the type of systems that you're using. And then lastly, that UHPs are interested in participating in the COE's work regarding PAs and community learning. So having that opportunity to share your experiences and also provide feedback were requested of us as an organization. So at this point, I'm going to turn it over to Alejandro, but I did want to pause and see if there were any questions, if there were any additional feedback. If you agree with what was said overall, averaged from responses, we'd be really happy to hear some feedback from you all too on that. I think the mics are open at this point too as well. And we'll just leave the chat open too. So if you want to write it into the chat, we can also come back and look over that too as well. So I'll turn it over to you, Alejandro.
Okay, yes. Thank you very much, Dr. Fowler. So as we mentioned before, we also had the regulatory assessment as part of the sustainability system assessment. And as you all know, usually the technical and technological fields are analyzed separately. However, policies and regulations, as you know, have a considerable impact on how operations are carried out. So the main goal was basically to know what the impact was of different policies on operations, and also check for potential opportunities to get additional resources for healthcare. The methodology was very similar to the one that Dr. Fowler mentioned. A survey, CoL, and we also did some offline research. So if we could just please go to the next slide. So for the demographics, it was important to analyze the demographics under the light of the regulatory system. So we divided the UHPs according to their number of patients, their number of patient visits, and the program funding. For the number of patients, UHPs range from 403 patients to over 20,000 annually. The average is 4,200. For funding, for instance, it ranges from 800,000 to 20 million. And the average is 6.8 million. Next one, please. So here, by divided by the number of patients, you will see the small are less than 1,000, large are more than 5,000. It is just very important, I think, to mention that there are a few programs, such as two programs in Oklahoma, the Tulsa program as well as the Oklahoma City, that account for a very large chunk of the numbers. And this could be, misleading. You will see the larger amount corresponds to the larger programs due to that. As we can see here, for instance, the small programs such as Baltimore account for only 4.9% of the total. So I just wanted to mention that. Next, please. So similar to the previous slide, the larger programs obviously account for most of the patient visits. In this case, the patient visits small are less than 1,000, whereas the larger one are more than 2,000. Next, please. In this one, we are analyzing the demographics by funding. The small is less than 2 million, where the large ones are those that are generating more than $5 million. We also show some facts. 86% collect funds from Medicare, Medicaid, and private insurances. The total amount collected through these means varies between 5,000 to 9.5 million. The average is 2.7 million from Medicare, Medicaid, and private insurance. Third-party billing funding is around 35% in average total funding for UIHPs. And precise, let's see, the third-party billing for small is 10%, for medium is around 12%, and the large is 40%. Next one, please. So this is a visual that summarizes the funding analysis. It includes IHS funding, that is the darker shade. Third-party billing is the lavender color, and dealer funding is the lighter shade. So as you can see here, as a group, the division of funds seems pretty even. However, if we analyze by funding, we will see some large disparities. For instance, for small programs, most of the funding comes from IHS. For the medium, the IHS funding is still important, but for the large programs, third-party billing collections are the main funding stream. Thank you. Next one, please. On a different note, the service provided, 79% of the programs provide full or limited ambulatory care, 36% provide outreach and referral, 21% provide alcohol and addiction treatment, 57% coordinate care with IHS and tribes, 50% serve non-Indian patients, 100% of all of the programs provide enrollment for Medicaid, 80% assist with the insurance marketplace, and 43% appear in the list of HHS's essential community providers. Thank you. Next. So finally, let's look at the regulation section. The impact of regulation. So this question was asked twice. How the regulations were impacting the operations of the program. And it was asked twice in a different way so that we could get a much better sense of where they were. It was interesting to see that when we asked UIHP leaders if they thought that regulations were fostering organizational development, 65% of them thought that the current regulations were fostering the organizational development, the program's development. And the way they thought this was being done, it was by bolstering infrastructure capacity, allowing for third-party billing revenue, and also to provide some stability. However, when we ask this question in a different way, we ask, if they believe that the current regulations deter organizational development. So 50%, half of them thought, the regulations were also deterring organizational development. And the way they are written or they are being implemented right now, they thought it was, these regulations were affecting in terms of inequities in treatment of UIHPs in comparison to, some IHS or trial programs. Respondents thought that there was no support for expansion, for renovations, information technology upgrades. They would limit the capacity to innovate in a bottom-up way. And this would make planning difficult. So this was just interesting to see the whole perspective in regards to the regulations and the impact of operation. And next one, please. Okay, so we surveyed also what were the needs of UIHPs. We realized that large and medium-sized UIHPs identified more like an inability to obtain new or expanded facilities as their greatest need. Whereas for small and medium size, it was more like identify the lack of key staff positions as their greatest need. Next one, please. So let's look at this chart that puts it all together. So on the far left, and I apologize because I'm sure that the font is very small, but I'm going to try to be as clear as possible. On the far left, you will see what are the contributing factors. In this case, in terms of the need for UHPs, we are analyzing, precisely what is the need for the expanded facilities. The service demand is larger than space availability, so services are limited, right, due to that. Or the cost of the space is too expensive, and so that is the need that we are analyzing in this chart. Here, as it is showed in one of the middle columns, some of the regulatory solutions to that would be additional funding from IHS, or the ability to use Title V funding to obtain new or expanded space. We could increase some of the solutions. It would be increasing funding via Medicaid at the counter rates. IHS can help to secure some federal assets. Some roadblocks that we see in this happening would be potentially lack of IHS regulatory support to treat UHPs like tribal health programs. Some historical factors, lack of space, and it is just a chart that shows a snapshot to analyze the situation. So that was so to show you what we just saw in a different light. Next one, please. Okay, so this is also showing a need of the UICs. In this case, would be more the concern of the medium and small UICs. Here it is the need for key staff positions. And some of the contributing factors to this need is that there is a lack of grant writers to get more funding for the programs. There is a lack of laboratory, pharmacy staff to serve the patients, or a lack of medical directors to facilitate the AHC accreditation. So possible solutions that we came up with was an addition to IHS line item to fund the key staff positions, some loan repayment for these key staff positions as well, a program in that tenor, or increasing funding via Medicaid services to allow UHPs to qualify for 100 FMAP. Just very quickly, if you do not know, I'll try to explain because it's a quite complex issue. But FMAP is basically the federal Medicaid assistance percentage program, and CMS reimburses these expenses at a rate of 100%. Services for eligible Native Americans in IHS or federal facilities cost, and it costs your state nothing if that happens. So non-Indian served by your facility can be reimbursed the usual FMAP, not the 100% FMAP. So we're trying to get this 100% rate covered for UHPs in this case. And if you have more questions about FMAP, I can ask some of my colleagues to send you an email about it because it's a little complex. But I just want to share that with you. Next one, please. Okay, excellent. Some changes in the federal regulations sought by UHP. So in terms of changes, specifically when we're talking about IHS-related regulations, the following changes are the ones that they would speak as the most important. A memorandum of understanding with the Veteran Affairs Administration so that Native Americans do not have to go back and forth between facilities to get full coverage. I'm sure you've heard about this before. An ability to operate CHAP or DHAP. CHAP is the Community Health Aid Programs, and DHAP, as you know, is the Mental Health Aid Therapist Program. Also, FTCA, that is basically the Federal Tort Claims Act, and that is essentially, for IHS to cover the insurance of malpractice for the UHPs. It doesn't happen with the urban programs, but it happens with our IHS facilities or travel programs. And also, as I mentioned, the FMAP, as explained before. Okay. So if you have any questions so far, I know it could be complex if you're not used to the lingo, just let me know, please, and I'll try my best. Next one, please, Kimberly. Okay, so for non-IHS regulations, providing Medicaid coverage for AAN, to the 138% of the federal poverty level in every state where UIHPs are located. Expanding grant opportunities in other HHS agencies, including UIHPs in capital funding by HRSA. There will be more or less, some of the regulations that are sought out by UIHPs in terms of non-IHS regulations. So that would be it. Next one, please. So here, specifically for regulatory activities, 86% of the respondents were interested in participating in our updates here at the CoL. 64% indicated having staff or a contractor who could participate, which we're very excited about. In regards to the third-party billing analysis, 79% of the programs collect Medicare, 71% collect Medicaid, and 71% collect medical insurance. From the marketplace, we have 43%, and from the HA, 7%. So those would be different revenues. Next one, please. Okay, for finally the legislative and regulatory goals, we asked the programs what would be the goals and also to rank them. So protecting UIHPs from reductions in Medicaid spending is the first one that came up. Increasing the congressional appropriations to the IHS, being a health service, would be the second one. Increasing the IHS application allocated to urban and health programs would be the third. Those would be the top three. Then we have designating the congressional appropriation to IHS as a mandatory spending. That will be the fourth one. Extending FMAP for UIHPs, which is the one that I mentioned before. Establishing an MOU with the Veterans Affairs Administration. And then extending SPCA, which is the one that relates to the malpractice insurance. Then the eighth one is retaining the Indian-specific provisions of the Affordable Care Act, which is all the provisions that allow UIHP to basically have them implemented as part of the Indian Healthcare Improvement Act. And then preserving the permanent reauthorization of IHCIA or the Indian Healthcare Improvement Act. Those would be in general as a group what UIHP would find as the legislative and regulatory goals that we will be working on as a sector. The next one, please. Okay, so the ranking of the legislative and regulatory goals, to some extent, vary by size depending on the IHPs surveyed. While large IHPs identified extending the 100% map for services provided to American Indians or Alaska Natives by UIHPs as a high priority goal, small and medium-sized programs considered this goal as a lower priority, and I'll show you that in a second. Next one, please. So here it is how, if we divide, the priorities per size of UIHPs, you will see the very dark purple, it shows the top. On top of this list, we'll see there are different, all the regulatory goals that we just mentioned in the list before. And then if you go to the far left, is the program size. On top of it, you will see, what are all of them together. The following line would be small ones, the following one is medium size, and the last one is large. So for the small ones, which would be the first, coming from the top to the bottom, the first purple, very purple one, you will see that for the small ones, the increase of IHS appropriation allocated to UIHPs would be, what they would select as priority. Whereas for large and medium sizes, the priority is designate the congressional appropriation to IHS as mandatory. So here, by size, as I mentioned, due to the difference of operations and scope of work, they have some priority goals. Of course, here at CoL, we work to make sure that, all of these regulatory work that needs to be done is done for every single site. But we wanted to know more or less where each one of the UIHPs were standing for this. So that was very, very helpful for us to understand better how to serve you. And I think that is the last part. Then we have a summary. You could go to the next one, please.
Alejandro, I did want to mention, too, just for clarification, the Indian Healthcare
Yes.
Improvement Act is the bill that contains the actual urban Indian health program line item, so the establishment of UIHPs, and so that's why it is a top priority for a lot of the programs. So having that permanently reauthorized was really important to the APA.
Right. Yes, thank you, Kimberly. Yes, the IHCA is the one that basically Congress has set up for as a mechanism for UHPs to get funding from IHC. Thank you. And yes, so if we could go to the next one. Thank you. Thanks so much. So as a summary, the regulatory assessment, federal regulations are perceived as both elements that foster and deter organizational development. As currently being implemented, some of the regulations foster and some of them deter the organizational development. So I think in the future we're going to try to clarify more the specific area so we can be more precise there, but it was interesting to see this dichotomy. Then, for the most pressing needs, we have expanding facilities and the key staff positions, as you may remember. These changes are viable if the changes in regulations from IHs are needed to address these needs. Most UHPs are interested in participating in the CoL work, which is something that we're very happy about in regards to policy and legislation. For the legislative and regulatory goals of UHPs, they are pretty consistent actually with what we have. Protecting Medicaid from reductions and extending FMAP% for UHPs, it is something that is on the top of a group. Depending on the size of UHPs, the regulatory goals and priorities vary, most likely depending on their most pressing needs. Likewise, although main concerns are similar for most UHPs, there are differences in the issues that UHPs see depending on their size. They perceive as priorities for UHPs to address their strategic plan. So that is the summary. And as I mentioned, if you have any questions, I'm more than happy to try to. I'll do my best. So next one, please. So finishing the assessment was not, like job done. We wanted this to continue and to provide us with more information to assist you better in a more targeted way, as I mentioned. So for the next steps, we have in HIT billing, there is going to be technical assistance, the AAAHC training held in June conference, data dashboard for monitoring and assistance, and technical assistance community of learning. What the next steps, and we're working on implementing that. For the regulations, the MOD project, we have now received a grant. It's called, the initiative is called Monitoring Regulations project, that is what it's called more. And so we, depending on the information that we gathered, or based on the information that we got from this survey, we are going to be working on the regulations that, you all provided us with the information priorities with. And so we have already started working on this initiative this fiscal year, and certainly we'll be reaching out to each UHP to keep working on these and assist you guys better. Kimberly, you may want to say something more about the HIT billing since I mentioned that.
Yeah, absolutely. So thank you all for your attention thus far. We're almost at the top of the hour. But I did want to mention that for our next steps for the HIT billing, as it was listed here, we did host that AAA training back in June at our conference that many of the programs attended. We're trying to find a better way of monitoring and assisting you all with, I'll say, downloading or uploading some of the information around the data that you collect through your EHR system. And so in order to help and assist with that, we are gaining access to the IHS's data dashboard, which would allow us to look at a more real-time of the data that's being entered into your EHR systems, mainly around the demographics of your patients that you're seeing, not on the clinical side, just more so on the demographics of who you're seeing and what tribes they're coming from, but also hoping that this will allow a better way to assist you when we see that there may be programs that are behind in uploading that data, and if there might be assistance for the non-RPMS programs to do so. And then lastly, the technical assistance community of learning. This is kind of like that first step in trying to understand what is needed, surveys for, first step in understanding what would be needed for that technical assistance and training community of learning, because we do want to develop something that is going to assist you in your work. And so I actually have a couple of questions here that I wanted to ask that you could take. You can even, we can go back to the previous slide deck if you just wanted to write answers in the chat pod too, but I did want to give you the opportunity if you wanted to answer here, you can. So we're trying to find out what are some topics that you would like to see covered in a more consistent basis. I know in the past we covered areas or provided assistance to provide information around ICD-10 when there was that transition from ICD-9, covering information on GIPRA. So if you just like to type in here some of your answers, we really appreciate understanding what topics you might want to see covered, especially in regards to the survey, which there wasn't any top concerns that kind of showed from the survey. It's just kind of everyone wanted everything, which may be the case. It may just be that you just, there's a lot of areas you want to see covered, and we can try to fulfill that. And then also understanding what best day of the week might work for community of learning. We did just choose Friday today just because it worked with our schedules, but we want to make sure that it also works for your schedules as well. So thank you for starting to take these poll questions. And then lastly, in regards to the regulations that Alejandro went over, we wanted to know if any of those regulations you think might actually have some kind of concern for you in the work that you do. So how much of not receiving malpractice insurance through IHS affects the work that you do. So if you could just select some of those for us, we really appreciate that. And you can select more than one. Forgot to state that on there, but you can do so. I'll just give you a few more seconds to put in your responses before we go back to the next screen. And then also if you would want to vocally state any of those, we're open to hearing from you in that way too as well. We really do want to make it a conversation more so than just us providing information in the future, so we'd really love to hear from you. I think I'll go back to the other screen. It looks like Tuesday and Wednesdays work best for folks, so we'll keep that in mind. And then just a big thank you for all for your attention. I know that you have lots of work that you could have been doing during this hour, so we appreciate your time, and we do want to make these opportunities ones that are beneficial to you as well. So understanding those topics once again will be able to help us do that. I did want to open up and just see if there were anyone that wanted to verbally make any comments. You can do so now as well. I think the line is open. Here's our information. You can always reach out to us as well via our phone or email, both Alejandro and I.
Yes, please. If you have any questions, just let us know.
Okay, so we're at the top of the hour. I think at this point we will sign off, and we'll take all of your poll question responses into consideration as we move forward in creating the community of learning that contains those topics that you all listed. Thank you for your time, and have a good rest of your day.
Thank you, everyone. Thank you, Dr. Bye-bye.
Thank you.